So let's continue where we left off. We were talking about some of the distal forms of RTA. Let's ground ourselves in this summary table. So we were talking about the causes of non-GAP metabolic acidosis related to reduced renal acid excretion. We reviewed the classic type 1 secretory defect. That is it's often an HATPase defect resulting in a distal RTA. Again, in its classic form, we call it type 1 RTA. We then discussed some of the voltage defect RTAs, including low distal sodium delivery, right? Volume depletion itself impairs the capacity to excrete acid. We talked about how patients with liver disease often have multifactorial metabolic acidosis related to lactulose, spironolactone, and low effective circulating volume, right? If you deliver very little sodium to the distal nephron, you cannot generate that voltage, that's negative voltage, for potassium secretion and proton secretion. So these are often patients that have concomitant hyperkalemia with their metabolic acidosis. We touched base on the fact that heparin is an aldosterone synthase inhibitor. I made the point that even Lovenox can do that. If I have adrenal insufficiency of any cause, that is a low aldo state, that would be expected to create this impaired proton secretion relying on this lumen negative potential difference. ENaC blockade with traditional diuretics or drugs that have an off-target effect on ENaC transport, like trimethoprim or pentamidine. Sickle cell disease is a scenario in which we see hyperkalemia and metabolic acidosis, so fitting this phenotype. And then if I have a mineralocorticoid receptor defect that approximates hypoaldosteronism, so-called pseudo-hypoaldosteronism, those would all be examples of voltage defects. Okay, so I hope that backtrack gets us back on point, and we can continue to move on to other forms of non-GAP metabolic acidosis of renal origin. Certainly the most common of those are the RTAs of CKD. Okay, that is a renal tubular acidosis as well, even though we don't have a numbering system to capture that very common form of non-GAP metabolic acidosis. So in general, we would say that more moderate degrees of CKD have this phenotype of non-GAP metabolic acidosis. Once you get to CKD5 or CKD4, that's when you start to see a broadening of the anion gap as sulfates and phosphates accumulate. So typically in these severe CKD patients, we don't measure sulfate, but you'll see hyperphosphatemia that coincides with this elevation in anion gap. Okay, so there's a number of mechanisms at play in the RTA of CKD, making measurement of urine anion gap fairly useless in interrogating this form of RTA. Remember, your urine anion gap is a measure or an indirect measure of ammonium excretion. There's a lot of flaws with that test. Okay, it's not a perfect test by any stretch, and it is not always fitting a certain pattern with the RTA of CKD. Okay, and in fact, there's a large publication on a large data set in CJSON that really makes the argument that patients with CKD have all kinds of urine anion gaps dependent on how much phosphorus they take in their diet. That's a major factor and confounds the use of a urine anion gap as a measurement of adequacy of ammonium excretion. Okay, so let's just summarize that the mechanisms are several. Maybe it's the fact that I cannot actually maintain a high gradient for effective proton secretion. What do I mean when I say that? Well, when you render your urine pH at 5.4, right? 5.4 in the lumen, and your blood pH is 7.4, you have 100-fold difference in the proton secretion across this epithelium. So it stands to reason that if I have CKD, I may have an impaired capacity to create that gradient. And so you may see in some CKD patients urine pHs that are not terribly acidic, that are in the 6s, 6.5, but that's not a universal finding, okay? Because if I also have low NH, let's say, production or delivery to this segment of the nephron, right? Ammonogenesis is impaired. I can secrete a relatively modest amount of protons and still have a free proton concentration that makes my urine pH relatively acidic. Remember, the urine pH is not a measure of total proton secretion, right? If it's bound by a urinary buffer, it's not going to be captured by the urine pH. Urine pH is a measure of free proton secretion. So if I have impaired ammonogenesis, for instance, because of CKD-induced hyperkalemia, right? We talked about hyperkalemia itself causing impaired proximal tubular ammonogenesis. I'm seeing nods. Anybody need that to be reviewed? We've gone over that a couple times. No shame. We're good? Or I'm looking at some people who are not nodding. Okay. Do I need to go over that? Go over it. Okay. All right. So remember, a proximal tubular epithelial cells. Suppose I'm in the proximal tubule. If I have hyperkalemia, K concentration in the cells of the proximal tubular epithelium, including all cells, is high, right? Because total body K exists primarily intracellular, okay? If intracellular K concentration is high, cations like protons leave the cell. If I'm a proximal tubular epithelial cell that is sensing proton concentration as a means to regulate ammonogenesis, right? That's supposed to be a delta. NH3 or NH4 production is regulated by proton secretion. Well, I'm going to decrease ammonogenesis because protons have left the cell. I have intracellular proton concentration that has decreased when I get hyperkalemic. Any hyperkalemia tends to reduce ammonium excretion rates because it impairs ammonogenesis. The inverse will be relevant when we talk about metabolic alkalosis. K depletion enhances ammonogenesis by the proximal tubule through the reverse. Intercellular proton concentration goes up in K depletion. Ammonogenesis goes up. Proton excretion then goes up, right? If I make more ammonia, I dump more protons. If I dump more protons, I get alkalotic. Okay, so hypokalemia is an important factor for maintaining alkalosis. All right, so again, if I'm hyperkalemic in CKD, I may have a problem with generating ammonia. Okay, or it's just the diseased proximal tubule, even in the absence of hyperkalemia, that cannot generate or trap distal nephron ammonium excretion. Okay, so there's a lot of different mechanisms whereby CKD creates a tendency to impaired urine net acid excretion. Okay. All right. So urine anion gaps are unpredictable. Urine pHs are unpredictable, etc. All right. So we've gone over some of the causes of metabolic acidosis. Let's just kind of review. That much of this will be review. This is all medicine for the most part, of how we approach a metabolic acidosis. I can hopefully move reasonably quickly. You can first proceed through a validation step if it doesn't make sense. Most of us will skip that, but I would offer that, you should have sufficient experience doing this a couple of times so that you at least know the principles in the Henderson-Hasselbalch if you're not memorizing the formula. pH is equal to the pKa, or the effective pKa, of the carbonic acid buffer system. Okay, that is 6.10. Okay, I can use Henderson-Hasselbalch with other buffers, but when I'm using it for the carbonic acid bicarbonate buffer system, I just plug in the effective pKa of that system of around 6.1. Okay, over or plus the log of bicarbonate times 0.03, over the product of 0.03 and PCO2. 0.03 times PCO2 is essentially just using the solubility, converting a partial pressure of CO2 into an effective carbonic acid concentration. Okay, this is just a conversion of partial pressure of CO2 to an effective molar concentration of carbonic acid, right? In the numerator, I have a molar concentration of bicarbonate. In the denominator, I'm trying to get the molar concentration of carbonic acid. So this is what Henderson-Hasselbalch is in general terms. pH equals the pKa plus the log of the conjugate base over its acid. Okay, that's the general Henderson-Hasselbalch. Here's the specific for the carbonic acid buffer system. Okay, now you'll know some of your rules of thumb for converting VBGs and ABGs. So VBGs do approximate the ABG, though there are some differences. Okay, as you can imagine, if blood is returning from the tissues, it's going to have higher CO2 concentration, right? That makes sense, right? It turns out that most of your CO2 is transported as bicarbonate. Okay, that's a med school principle that we're reinforcing here, right? So CO2 gas, dissolved CO2 gas, is not the predominant form of CO2 as it's transported around the body, right? When CO2 is dissolved in biologic fluids, carbonic anhydrase essentially converts that to bicarbonate. Okay, you put some of that bicarbonate or chloride bicarbonate exchange occurs at the red cell plasma membrane. ECF bicarbonate concentration goes up in venous tissues. Okay, so you can see that that's a bit higher. VBG calculated bicarbonates tend to be a little bit higher. It makes sense because, again, CO2 is transported as bicarbonate, right? 80% of CO2 is transported as bicarbonate. Okay, the net is a pH that is slightly lower than the ABG, right? By about 0.1. Okay, PCO2 again is higher, but it can be even higher when you have impaired circulation, right? It can be very discordant from what an ABG PCO2 is. Generally speaking, we can rely on the VBG to determine whether there's a respiratory disturbance by taking seriously what is the CO2 concentration of a VBG. Be cautious about using that interpretation in the patient with shock, right? Because it can be much higher than the arterial CO2 concentration and lead you to an erroneous conclusion. The patient has primary respiratory acidosis. Okay? All right. We can calculate the serum anion gap, right? In order to start to construct our differential diagnosis. If there is an anion gap, you can essentially correct for the presence of that strong acid. And people use deltas. I tend to just use a more intuitive approach of, if my normal anion gap let's just say normal anion gap is somewhere around 10, okay? And my serum bicarbonate in this hypothetical patient, right, is, let's say, 20. But the anion gap in this patient, let's say the anion gap in this patient is, let's say, 20. Okay, let's use easy numbers, right? Then what I say is, well, about 10 of this anion gap, right? The anion gap minus, let's call it the normal anion gap, normalized to any serum albumin perturbations you have, right? If my albumin is low, my anion gap, my normal anion gap is lowered by that, right? One of the main contributors to the anion gap is your albumin concentration, a protein with negative surface charge, okay? So if I have an anion gap of 20 when normal is 10 and my albumin is normal, then I can say that I have consumed about 10 millimoles per liter of bicarbonate by the presence of this strong acid. So if lactate or keto acid was not present in this patient, I would give him back those 10. And so pre-lactate or pre-keto acid, they had a combined metabolic alkalosis, right? Okay, so some people, again, use deltas. I think this is the more intuitive approach. Take your anion gap, subtract your normal anion gap, which is corrected for any disturbance in albumin that may be present. Subtract that anion gap, that normal, from your observed, and that is the bicarbonate that was consumed by that strong acid present. Give it back to the patient and see if they had a combined disturbance. Okay, everybody like that or get that? You may not like that, but do you get it? Okay, all right. Okay, so I've said all of this in these words. I don't know that I need to belabor that. You can measure an osmolar gap if you want to see if there's a weird ingestion, if this picture is not fitting, right? If it all makes sense, right? Their lactate is roughly, their plasma lactate concentration is roughly equal to that difference in anion gap. Don't bother. Why do I need to measure an osmolar gap? Let me make a point, however, is that lactate and keto acids, they're osmoles, but they don't contribute to the osmolar gap. Why? Because they are charged osmoles and they obligate a cation. So for every keto acid that you have a sodium or a potassium. Your osmolar gap relies on 2 times my sodium, right, in order to capture sodium and its anions. Okay, so then lactate and keto acids are captured by the 2 times sodium term, and they therefore do not contribute to an osmolar gap. You need an uncharged alcohol, for instance, to contribute to the osmolar gap, or the mannitol. These are uncharged. These are not strong ions, right, that dissociate. Okay, so in the case of non-anion gap metabolic acidosis, the shorthand to look for is what's the urine pH, right? Outside of the CKD context. I told you CKD is a messy landscape. But if you don't have CKD and you have a non-gap metabolic acidosis, you want to see that the urine pH is quite low. Okay, that should be normal for you and me. If I even have a pH of 6, right, then that's abnormal. Okay, now, and that could be indicative of an RTA. However, there are a couple of exceptions to that, right? If I have urease splitting bacteria in my urine, that would ex vivo, all right, or at least in the bladder, post tubular, I have a change in pH, right? The renal tubules dump the proton, but downstreams, wherever the bacteria is residing, I've taken urea. Urea basically takes urease, takes urea and splits it into NH4, right? Urea is neutral charge, right? So NH4 is positively charged, right? So I must have a balance of some negative charge, and that is bicarbonate, okay? So urea is converted into ammonium and bicarbonate. The bicarbonate raises my urine pH, right? So I might have a high urine pH even though I have no RTA. If somebody has a urea splitting UTI, right? Okay, so that would be an exception where a urine pH may not be indicative of an RTA. Now, if I have severe hypokalemia, that can be a scenario in which my urine pH is not so low, okay? We've gone over these concepts, so I can go reasonably quickly, right? So remember, urine pH is free proton concentration, right? That's what you're measuring when you're measuring pH. Hypokalemia in the proximal nephron increases ammonium generation rates, right? Okay. So if I am making more ammonia and I have more ammonia available for buffering protons, even though I may be having intact proton secretion through HATPase, my free proton concentration is still not maximally high, or my pH is not maximally low, right? I may be dumping plenty of protons, but the presence of so much ammonia allows my free proton concentration to be such that my urine pH is not 5.5, but is rather 6.5. So hypokalemia, which is common in diarrhea, right, can actually make your urine pH not maximally acidic. All right? Okay. So finally, urinary diversion through an ileal conduit is a cause of impaired urine acid excretion, but is not an RTA per se, right? There's nothing wrong with tubular function. Renal tubular function and urinary diversion is not problematic. The problem is, as we previously discussed, is that my kidney, okay, did its job. If I were to sample, if they had a PCN, right, if they had urinary diversion and you put a PCN in this patient, you would check the pH and the pH would be 5.5. Ammonium excretion rates may be high, right? If I checked via PCN. But in that ileal diversion, right, the drainage into a loop of bowel before it's anastomosed to the skin, right? It modifies my ammonium concentration or content as well as my proton concentration. Okay. What does it do? I reabsorb, okay, ammonium through this loop of bowel. Remember, ammonium has the molecular properties that approximate free potassium. So it hijacks potassium transporters, right? That means my ammonium excretion rate through the stoma is diminished, right? And then also there is chloride bicarbonate exchange. Bicarbonate enters, chloride is reabsorbed. So my free proton concentration goes down because bicarbonate enters the lumen of that, let's call it a neobladder, right? So when you check the urine pH in these patients, it's high, the ammonium excretion rate is low. All right, moving on, because nobody's slowing me down. In the case of non-anion gap metabolic acidoses, you can measure the urine anion gap and the urine osmolar gap. Okay, so here I've given you the definitions of urine anion gap as well as the caveats. Okay, I've given you the caveat, which we've already reviewed, that urine anion gap can be confounded when there is an anion in the urine, right? That is a conjugate base of a strong acid, right? Like keto acids, hippuric acid, anything that's negatively charged that you're not measuring, right? You're measuring chloride in the urine anion gap. That doesn't create this confounder. But if I have keto acids in my urine or hippurate in my urine, you don't typically have much lactate in the urine. Sometimes you can, but your kidney reabsorbs a lot of the lactate that is being produced in lactic acidosis. Okay, but in certain circumstances, lactate can be a meaningful contributor to this confounder. Generally, it's not. Okay, again, urine anion gap should be negative if the kidney is doing the right thing. That means I'm excreting ammonium. Okay, but if some other negatively charged species is present in the urine, it can confound the urine anion gap, make it positive. Okay, urine osmolar gap is not confounded by the presence of these anions. Here's the formula. It should look reasonably familiar. It looks exactly like the plasma osmolality calculation, except you include potassium, because unlike plasma, you can have a lot of potassium in your urine. We ignore it in the plasma calculation. This is not going to be confounded by the presence of an anion. You should see an osmolar gap that is just large. Okay, this is not negative versus positive. You want to see a large osmolar gap, right? What is large? You know, it's not 101 is large, but 99 is not large. Right? This is, as Orson often says, not a pregnancy test. Okay, this is, use your logic to say, this doesn't sound right. Okay, it's not large enough. All right, so now urine osmolar gap is not perfect, in large part because we can't get it when you have glucose in your urine. We've already gone over that. But there's another confounder, okay? That is when I have this urease that's functional, okay? Right? Because when I have urease, I am producing more osmoles by splitting that urea into ammonium and bicarbonate, right? And so that can make my urine osmolar gap, again, post-tubular, right? It's going to look large, right? Meaning it can overestimate my ammonium excretion, right? Because you took urea and you split it in two, right? So you've increased your urine osmolar gap by the presence of urea, but that's unfair, right? You need that intuition of what's happening in the tubular lumen, not in the bladder, in the UTI. Okay? You actually do excrete some alcohol in your urine, even ethanol, believe it or not. So that can confound your osmolar gap. Okay? And then there's the respiratory compensations. Whenever you have metabolic acidoses, you'll recognize some of these formulas for acidosis and alkalosis. Here they are. Okay. I don't memorize them. I look them up. Okay. Reasonable on time. Let me just take a look at this. Okay. We're going into the alkalosis soon. Okay. Bicarbonate deficit. We talked about this in our essential nephrology in your first few days, believe it or not. Well, that seems like a long time ago. All right. Because your brain has swollen so much with knowledge, right? Okay, so bicarbonate deficit is a way that you can intuit how much bicarbonate you need to give quantitatively in order to achieve the serum bicarbonate that you want. Okay, I won't belabor this because presumably this should be familiar to you and you should have used it, I would imagine, because all of you have been on consult months thus far, and I'm sure you've encountered some severe metabolic acidosis, and you said, not just start bicarbonate drip and recheck, but you said, give this much bicarbonate because they need this much, right? So how do we do that? We need to know the volume of distribution of bicarbonate, which is variable, okay? In patients that have relatively modest amounts of acidosis, right, a bicarbonate greater than 10, it would be roughly total body water, right? But once you get more severe metabolic acidosis, your effective volume of distribution goes up. Okay. What is happening in those scenarios? When you're severely acidemic and you give them bicarbonate, some of that bicarbonate essentially just vanishes literally into thin air, right? When you give bicarbonate and someone is acidemic, it goes into CO2 and water, right? So the bicarbonate does not augment when proton concentration is very high. It just blows off as CO2. So that's why the effective volume of distribution goes up when you're more acidotic. Okay. Now here are the terms in that formula. Let's then decide what kind of alkali I want to give. Once I've determined I have a 200 millimole deficit in bicarbonate to go from this bicarbonate to my desired bicarbonate, right? And you simply need to know what is the alkali content of the various prescribable things. An amp contains 50 millimoles. When you put 3 amps in a liter, that's going to be roughly 150 millimoles per liter. Not quite, because the volume is expanded a little bit, right? It's not quite a liter after you add 150 cc's. But for all intents and purposes, it's 150 millimoles per liter, right? Each tablet of sodium bicarbonate has a very small amount. So when you want to make a move on a serum bicarbonate in a day, you don't generally want to do that by just sodium bicarbonate tablets. We also have Bicitra, where each mill contains 1 millimole. You can move pretty quickly. This is very hypertonic. You can get hypernatremic, similar to when you push multiple amps of bicarbonate. That is hypertonic bicarbonate. We also have potassium-containing liquid, which is sometimes used in your RTA patients who can't tolerate, for instance, the tablet Uracit. You can give them Polycitra. And we also have the tablet Uracit K. Okay, that is actually labeled in milliequivalents, so you get to it's on the label how many milliequivalents of equivalent bicarbonate that you're giving. Okay. All right. So it's captured, right? Sodium citrate. Citrate is a 3-, right? And this milliequivalence, it captures the valence of citrate. It just so happens that citrate, when it's metabolized, generates 3 of bicarbonate. So the shorthand is take the milliequivalence. That's how much is in each tablet of potassium citrate, right? Okay. With that, we get to move, if my computer doesn't shut down, it looks like it's on its last battery life, into metabolic alkalosis.